Good morning, everyone, and welcome to the Stroke 360 Symposium presented by the Houston Methodist Neurological Institute. It's been a quarter of a century since the advent of thrombolytic treatment for stroke and the modern era of acute stroke therapy. The last 25 years have been a remarkable period of revolution in acute stroke treatment and stroke prevention. And now we're seeing a tremendous buzz of activity in the fields of neuro-restoration and recovery. It's been a palpable shift, and one that's quite welcome to me personally, because quite frankly, we still face a large therapeutic gap on that front. For this morning's session on neuro-restoration and making the patient whole, we'll start off with a talk on robotic-assisted stroke intervention by Dr. Gavin Britz. Dr. Britz is the Candy and Tom Knudsen Distinguished Centennial Chair in Neurosurgery at Houston Methodist Hospital. His career has taken him through South Africa, the University of Washington at Seattle, and Duke, among other places, before he joined Methodist Hospital in 2013 as professor and chair of the Department of Neurosurgery. The major focus of his clinical practice and research has been cerebrovascular diseases and brain ischemia. Dr. Britz, it's great to have you. Take it away.
Jay. Anyway, so I think as Jay said, this is real day talks, and what I'm going to talk to you today looks like it's going to be far-fetched, but it's really going to happen pretty soon. So we're going to talk today about the feasibility of robotic-assisted stroke interventions, and how we started it here at Houston Methodist about 2.5 years back. So if you look at this slide, as you can see here, you can see a humanoid. Or it actually looks like some of the modern kids in this world these days. And then you have this humanoid sitting in a control panel, and he's controlling an angiogram suite up in space. And I think that people would say, well, is this possible? And I think this was the cover of one of the major journals on this publication, and I'm going to show you how it is possible in the near future. So I think, we always, I think as Jay and Volpe and everyone knows, that the way we grow forward in healthcare, in medicine and in science is we always stand on the shoulders of our predecessors. And I think the first steps in making all of this possible was the major shift away from open vascular neurosurgery towards the endovascular. I'm a very, very well-trained open cerebrovascular surgeon, but even I saw the writing on the wall many years ago and trained in endovascular. And we do know, even as an open neurosurgeon that does endovascular is the future. It results in faster, safer, more efficient treatments, and that is spread across the cardiovascular system, the peripheral vascular system, as well as the neurovascular system. And a lot of this is related to having the vascular highways where you can access the disease processes directly through the vessels, and you can get there without opening the heads, etc., etc. I think that was well developed, and the question then became is that why robotics? We were doing a really good job with manual dexterity in regard to the thrombectomies and neurointervention, and I think I divide them into 4 aspects, and I'll show you how they work in this robotic device. The number 1 is automation of dangerous activity. The 2 is remote stroke, which we'll talk about. 3 is remote proctoring. And I think 4 is radiation exposure. And I think the first thing, I think that, we know that manual dexterity is good, but it has a limit. So one of the big features of why we developed this robot is that if you can imagine taking the dangerous part of the procedure and make it robotic and also completely foolproof, which is a very, very important thing in surgery. I think that's one thing which will show you how the robot is going to change neurovascular interventions. The other thing is remote stroke. Imagine is you can treat your thrombectomy by a very experienced thrombectomy expert in Colorado while someone's in holiday and not have to ship them out. We all know that time is brain, and I think a robotic assisted thrombectomy from someone experience in a remote setting is definitely going to save patients time and save brain cells. The third thing is remote proctoring. I think all of us, I don't do much of it anymore because I'm busy, but as we all know, we always fly around, proctor people to do this. And if you can imagine, you can sit in your own angiogram suite and proctor someone sitting around in their suite across the country. And the fourth thing, it's not the least, but radiation exposure. The data clearly shows that interventionists have increased chance of cataract formation and also actually even have increased chance of malignant tumors of the brain on the left side, because we're always standing on the left-hand side. So these are the four major reasons that when you think about it, why was robotics important in at least getting it started, let alone the remote stroke aspect of it. And I think as when you look at this slide, and we had stole some from the web, but one or two we made ourselves. As you can see, this is the future. We in neurosurgery have got 3 research programs. One is brain tumors, one is restoration, which Phil's going to talk about. But the other thing is neuroprosthetics. And what this is that we are going to have a handshake or a joining of prosthetics and engineering in the future for the brain and spinal cord. And I think robotics will show you exactly that. So this slide shows where I think the future is going to be. And it's not even the future. I think, as Jay has said, this is part of who we are today. We have chips in people's brains today, and this is where we're going to be, and this is where we're going to grow in the future. So this started many years ago. As I said, 2 years ago, we said, well, there are robotic technologies in the heart, but there's nothing really available for neurointervention. There was this robot, the Corinthus robot, that was being used for cardiovascular, and we said, well, let's take that platform and let's see if we can convert that into a neuro platform with a neuro small wires, etc., using the 014 guide wires, the small 2.4 French microcatheters, and see if we can do it in the lab model. So this is what the robot looks like, and this is actually the robot in the Mighty. If you look at your left panel on the left-hand side, that's what the console. So the surgeon or interventionist will sit there behind that little panel, and there's, at this stage, on this model, there's only 3 arms. We can move some of the catheters. And on the right side, if you look, I can't point, but anyway, sorry, where's? If you look at the right side, that's actually the robot itself, and the brain behind this operation, which moves the catheters. So this is what we took this robot, took it down to the Mighty, which is our educational suite, and started doing experimentations. And just to give example, that's what the brain of this robotic device looks like. And this was a device purely developed for cardiovascular, and we said let's try it out for neurovascular. And these are some videos. So I hope we can play these videos. Can you guys show the videos? I'm going to push. Let's see. I can maybe play it. Because there's a lot of videos. That's the important part. No, go back to the first. No, that one's got a video as well. Okay, that's perfect. Yeah. So if you can see here now, I'm sitting behind the console in the upper corner, and I'm actually moving the joystick. As you can see, the brain of the robot is moving. And if you look at the flow models below, can we play the flow models below? You can see us now manipulating these microcatheters and microwires in a flow model, and that was essentially the first time this was done in a flow model for neurointervention. And we'll go to the next slide and we'll show it better there. Okay, play the video. So that's what it is. So here I'm sitting in a console about 4 feet away from the device, and I'm actually taking a coil and robotically placing a coil in this flow model. And that was essentially okay, this is possible. And if you can see it there, this was done 2.5 years ago using really the worst coils available. And you can see there's even the painting effect of this coil. And we've done this robotically. And I think that was the first study that said, okay, this is going to work. Using a simple cardiovascular robot, we can go ahead and coil some aneurysms. And that was a flow model of an aneurysm. So then we said, okay, well, let's find in a flow model. Let's see if we can do it in the pigs. And as you guys, your pig's got that rete, which is internal carotid circulation, but it looks like an AVM. Okay, let's play that video. Let's play that one and blow it up. So yeah, we've got the roadmap done now in this pig. And as you can see, we're taking this little wire robotically with not me touching the pig, taking that wire all into the internal carotid artery, into the reti of the pig. So that was, again, you know, first ever done in the world, and we actually managed to do that with the pig. So then we had now a flow model working well, we had a pig model, and then we actually doing a run that we had to do manual, which can show that we can actually even do runs through this reti. And next slide. So then we said, okay, well, we've coiled in a flow model. We can navigate into the reti. Let's play this video. We're now going to take this wire and go coil that reti. And there we go. You can see there now. And again, robotically, we're placing the coils in this animal, an euthanized animal. And again, you know, first in man to do this. And that's, again, set the stage for where we're going to go. So then we said, okay, well, let's place a stent. I mean, that's going to be the highest, and let's try and navigate our microwire through a stent. And again, you know, to save costs, that wire, let's play this video, was the cheapest wire. We placed the stent, and that video didn't come out so well, but we placed that stent in that flow model, and using the worst wire that I could ever imagine. I've never used in a human. I'm going through the stent, again, purely robotically, no hand there, and actually can go inside this aneurysm purely through the robot. So now we had the stage where we can almost do anything with a simple cardiovascular robot, and we've shown the feasibility of that. Next slide. Okay. So that resulted in one of the first papers. We published that. And then we said, fine, let's go on to the next phase. So obviously we were looking to see how we can use this. And the next one is to see how we can use a pig model and to go embolize an AVM, which is very similar. Let's play the video. And again, as I said before, the reti is a very good surrogate for an AVM. In the next video, let's play this, and it'll show that we can do the runs. And then can you play the video's not going? The second video, you can see it, yeah. Okay, there you can see it, yeah, now. It'll come in a second. And we actually, you can't see it clearly now. Oh, there you can see it. And there we got the onyx, which is the embolic agent, which we're now injecting into the reti as a surrogate for an AVM. So now again, that's the next phase done. Okay. So that, you know, was a great start. You know, we got a few publications out of that. But as I said to you before, for me, and you know, I don't have any fellows yet. We'll start getting fellows again starting in the next year. But when I was at Duke, I had 2 endovascular fellows, and you know, running into rooms, and you know, unlike what the world believes we are, and we're not all equal. So even amongst our residents and fellows, some are just better at procedures than others. And I think one of the big things I did notice, which always worried me when my fellow was doing the coiling of an aneurysm, was how someone can manipulate a microwire better than others. And when you push that microcatheter over the wire, it would jump forward. And people with natural dexterity will automatically just pull it back, and others wouldn't. It can actually go perforated. So one of the big things about this robot, and we worked with a company, was let's see if we can make this better and take away the human element at risk of this robot. And that's what we did. So next slide. That's where I'll put it. Okay. And what was developed? Okay, let's see these videos. The first video first. So there's again, it's an aneurysm created on the carotid artery. We're going to go inside. Is the video playing? This is really a cool video which can show how technology is going to make things better. Can you place the video? Play the video. It's not playing, is it? Okay, so the first video, you can see the wires going inside, and now we are going to go and push the microcatheter. And okay, it didn't show, but if you play it again. But if you can see carefully, you can't see it too well. Yeah, now they just They're not going in sequence. But if you look at the first video versus the second video, when you push the microcatheter over the wire jumps forward, and that can result in perforation risk. If you look at the second one, you can see we can navigate the wire into the aneurysm, and then using a software device, which we called at that time active device fixation, which we call proximal device fixation, the computer automatically prevents the wire from migrating forward, and that solves the problem. So I can have a fellow now robotically migrate the wire into the aneurysm. I can push a little button on the computer, and that wire will not move, and that's what we call proximal fixation. So this negated the concern of having the fellow not having dexterity of the others and can prevent perforation. So that's an example, as I said to you earlier, on number 2. This is where robotic devices can make a difference, and again we publish that as a paper looking at how the robotics can actually make interventional even safer. So the big question for, obviously this is a stroke meeting, but I just gave you a background in regard to, you know, where we are. Are we ready for stroke? So I think a lot of us, we know as interventionists, we know that the easiest procedure we do is stroke. Technically, we don't always get the results we want because clots are different. Like the one I did on, I think on Saturday, you know, first pass opened up, but the clot occurred in the OR, clot went up, opened it up. Particularly in the extended windows, it's not, you know, it doesn't always come out as well as you want to. But the technical component of taking a wire and putting a wire into the MCA is pretty easy. So all you are, if you look at the left panel, that says an image of a left M1 occlusion. All you're going to really do is take that micro wire, the catheter, over the clot into the MCA, and I can guarantee, even though David Chu's never done intervention, if I spend 5 minutes with David, I can teach him how to do it. And then all you do is deploy the stent. I've already showed you that the robot can coil aneurysms, can navigate vessels, can navigate anything you want to do. So why couldn't a robot do what we do in the angio suite? Because it can do it in flow models, etc. So this is possible, as you can see. And I think what we have is a stroke meeting. Why is remote stroke important? As we all said earlier, time is brain. I think that the resources are not equal in this country, particularly in the rest of the world as well. So if you have a stroke in a small town, you're going to have to take hours to get there. So you can imagine a robot can take care of your stroke in a remote fashion. So the whole plan would be that someone has a stroke in a small community hospital, you have a vascular surgeon or even a physician assistant. They can place a sheath in the groin, and then the interventionist from any place in the world can then go ahead and do the thrombectomy remotely. And this is another paper we published. I'm not going into detail because that's more of a neurology thing, is how we devised a novel solution to simulation care based on what I just said to you. The moment it's strip and ship, do you keep them in the hospital? Do you have many primary cares, many tertiary care, stroke centers? But I think with the robotic device, when it's up and ready, it's going to completely change the paradigm. So, completely place the paradigm. And obviously, in regard to the stroke robot, I'm working with a company now at Siemens, and I think we're going to have the first available device for remote stroke in the world in less than 18 months from now. We also were involved in regard to looking at, sorry, this is not, hold on. We're also looking at, doing the first in man. We were ready to do the first aneurysm in man, and unfortunately the FDA said no. So we said, okay, well, we're still going to become the first in man in something. And we did the first robotic trial in regard to looking at this robot in humans. So we published this, we went inside, and in most of my Moya patients, we used the robot and we accessed it. And this paper clearly showed that this is feasible in humans as well. So the other question people say, well, what about the delay in stroke? You showed this video of the guy in space, and that is a good thing. That is a good question. And I think what we looked at studies with Alan was looking at myself, and we published 2 papers looking at it. And with the robotic device, and again, AI and algorithms, you can develop an algorithm that allows the surgeon or interventionist perceive what is a real delay and what is not a delay, and we calculated how many milliseconds a delay was possible and feasible. And as long as there's no delay more than, I think it was 0.33 seconds, we wouldn't even notice it as a human being that we have any delay in moving the catheter to getting the data that we can see. And we published those 2 papers, so based on that alone, we can say that's feasible. I think with 5G networks just arriving in America, and I think with long-distance networks being developed all over the world, I think if we can keep our delays longer than 0.33 seconds, we can treat a thrombectomy right now in strokes. So I think, just to conclude this, the new robots are coming. The robots we started all this work on was 3-channel robots. We've now got 4-channel robots that have been developed. We're going to have robotic devices, guide catheters, microwires, etc. This is not the future. I think we're about 18 months away from having the first stroke robot. It won't be in America, unfortunately, but it'll be probably New Zealand or the UK. But we've been part of this journey, and I think it's going to be exciting for us to move forward. Thanks very much.
Well, it's a fascinating look at the future. Thank you very much, Dr. Britz.